This week on the BackTable podcast.
If I were to just give you the big takeaways. Number one, patients got better faster. If you looked at how they're feeling, several parameters in terms of hemodynamics or their RV function at 24 hours, they were all improved. Number two, there were few patients who had clinical deteriorations and bailouts. In fact, it was threefold higher in the catheter-directed thrombolysis arm versus FlowTriever, which is very significant. Other big takeaways were less ICU length of stay, 1 day less hospitalization overall, and then readmission rates were decreased by 60%. And all of this was done in the context of extremely excellent safety profile with a large bore thrombectomy device. So to me, this really changes the standard of care for patients that we choose to intervene on with intermediate high-risk pulmonary embolism.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is backtable.com. Very easy to remember. Subscribe to the show, leave us a review, or reach out to us on social media. Now, a quick word from our sponsor.
The Inari Learn program is a full-year educational program offered by Inari Medical. The program is for physicians in training to learn about the diagnosis, treatment, and management of venous thromboembolism through a multidisciplinary curriculum curated to suit both interventional and non-interventional physicians. With a combination of virtual, live, on-demand, and in-person events, program participants can complete the program on their terms. By the end of the program, participants will have a solid grasp of VTE patient selection, procedural tips and tricks, clinical data, and fundamentals of a VTE program, all while building a network of peers and mentors that will enhance their educational journey and elevate their career transition. For more information or to register for the program, please visit the Inari Medical website and navigate to Residents and Fellows programs, or speak with your local Inari sales professional. Now back to the show.
Our topic today is pulmonary embolus, specifically large bore mechanical thrombectomy with a focus on Inari's Peerless randomized control trial. To help me with this topic, we have Dr. Zarina Sharalaya and Ripal Gandhi. Doctors, welcome to the show.
Thanks for having us here.
Thank you.
All right, Zarina, we'll start with you. Interventional cardiology always goes first on this show, always gets preferential treatment, as they do in the cath lab. If you just tell us background and training.
Yeah, so I am fairly early career, just 2 years out of training, but I'm an interventional and structural cardiologist. I graduated from medical school at Ohio State University and then went on to do residency at University of North Carolina in Chapel Hill. So then I went on to do general cardiology and interventional cardiology at the Cleveland Clinic and just moved down to Dallas to take on my first job, and it's an interventional and structural role. So
how did you find yourself in the pulmonary embolus space?
Yeah, so basically where I trained, none of us, no interventional cardiologists did any PEs essentially, and it was very much a space that was sort of dominated by interventional radiology. And so when I joined the practice that I'm with right now, one of my partners was actually very involved in starting to build a PE program. And honestly, I had no idea why a PE program would even be necessary or the importance of it. And, it's really become clear to me how important this space is. As I've started to do thrombectomies and manage PE patients, it's really striking to me how much of a difference you can make in someone's life pretty instantly. And in my opinion, it's equivalent in many ways to taking care of a patient who's coming in with a STEMI, where they will instantly feel better with whatever you're doing, and not only feel better, but it's life-saving. So I think that the diversity of patients that you treat is pretty amazing as well. And from young women who are on birth control or recently pregnant, all the way up to your older population of patients. So I think it's been a really rewarding space to jump into.
Very nice. Ripal, Miami Vascular is in the house. I think you guys are we have more people on the show from y'all's facility than any other facility. So thanks for coming on. Will you just give us background and training and how you got into the PE space?
Sure. Yeah. I've been in practice now for a little over 15 years. I don't know where the time went. Went to medical school at Northwestern, did a surgical internship at Cornell, and did my residency and fellowship at UCLA, and I've been in Miami ever since. We started with treating pulmonary embolism, I was treating pulmonary embolism as a resident. Obviously, the devices were very different back then. We would do things such as, spinning a pigtail catheter, even utilized angiojet. And obviously, as the technology has improved and we've gotten more data to be able to treat pulmonary embolism, it was something that really kind of came naturally. And we really instituted a PERT program at our place pretty early on. And this was really an area which I really like because there's not a lot of data, a lot of area for innovation, a lot of area for doing research, and a lot of area for improving the care of our patients. And as Zarina stated, these are patients that you could take really sick patients and really make them better instantaneously on your table. And, of all the procedures that we do, I think it's one of the most gratifying as an interventionalist to take a patient who's very sick, maybe hemodynamically unstable, not doing well, and instantaneously make them better. And that's something that really led me to kind of really pursue research in this area and really led to my interest in this area.
Oh, very nice. I know I told you guys offline that we would do the big focuses would be the procedure and then the data, but actually I also want to talk a little bit about the workup. So let's start with that. Zarina, we'll start with you, kind of open-ended. What does your workup look like, or what does your referral look like, and then what does the workup kind of look like?
Yeah, so basically our referrals are generally coming from ER doctors. So generally what they call me after seeing, it doesn't even have to be bilateral PE or saddle. It's just a PE, and it actually ends up being interventional radiology, vascular surgery, and interventional cardiology that takes call for PEs. So, somebody's on call every day. So basically when we get the call, usually my big criteria that I'll ask the ER doctor for, number one, especially if it's a larger burden thrombus or a saddle, I'll ask for a stat echo. And that is very helpful just for me to help plan the procedure. And I'll kind of go into a little bit more about why that is. But troponin, proBNP, and lactate, these are all really key things that I think should be obtained for each PE patient, because I just think it sort of helps you risk stratify them a little bit further. If you have somebody who comes in with an intermediate risk PE, but their lactate is 5 or 6, you know that this is something you're probably not going to want to sit on for too long. So I would say, in addition to the CTA, those lab values, obviously you're going to look at the patient's vitals, and then an echo is really key along with a venous duplex.
Okay. Ripal, same question. Similar workup. How does yours differ?
We're pretty similar in terms of workup. We get imaging, we get an echo, we get biomarkers, troponin, proBNP, and lactic acid, and we kind of go from there. And obviously, the most critical thing initially is, is this patient high risk, or are we looking at an intermediate risk patient? As our kind of treatment algorithm will differ on the basis of how sick they are.
All right, so you have all the, you kind of touched on it, Ripal, and that's the kind of the crux of what I'm trying to get into. Will you talk about how you stratify the patients, and once we do stratification, we'll kind of mean what that means for your decision algorithm?
Sure. Yeah, we typically utilize the European Society of Cardiology, the ESC classification, really stratifying patients into high risk. These are the patients that are either hemodynamically unstable, on pressors, probably represents about 5% of the total patient population. A low risk, these are the normotensive patients, what I would consider a garden variety PE. And then the patients at intermediate risk, which, depending on the statistics that you look at, constitute at least a third of patients, maybe even up to 50%. These are patients who are normotensive, but have evidence of right heart strain. And whether seen on a CT or whether seen on an echo, with or without elevated biomarkers. And we further risk stratify them or subcategorize them into intermediate high risk, in which they have both imaging evidence of right heart strain as well as elevated biomarkers, or just one or the other, which is intermediate low risk.
Got it. Zarina, any differences there, or pretty standard?
Oh, pretty standard, yep.
Depending on how you stratify your patient, will you talk about what that means for what you're going to do with the patient next? How the treatment algorithm flows from that stratification? We'll go with Zarina.
Yeah, so, I think especially this intermediate risk group, they can be a little bit deceiving at times. I remember I just had a patient recently who they were admitted, stable blood pressure on a couple liters, but then these patients can drastically deteriorate fairly quickly depending on how much thrombus there is. So I, especially as a cardiologist, I rely a lot on echoes, and an echo can really sort of give you an indicator of what you're about to get into. So generally when I start the case, I like to know what their RV pressures are, and you can get a fairly cursory understanding of that from the echo. So if I see that their RV pressure is upwards of 60, I know that, I'm potentially going to need some backup. And it makes me basically, when I go in to actually do my right heart cath and get my opening PA pressure, if I see a number upwards of 70, I'm going to be really hesitant to start the case without some sort of backup plan in place. And so what I mean by that is, in some institutions, this might sound a little bit aggressive, but we have gotten into situations where we actually start doing thrombectomy in these patients, and they deteriorate fast. And if you lose a pulse in that situation and you start CPR is not going to be doing too much for them, unfortunately, because you have no gas exchange taking place because of all that clot in the lungs. So whenever I see PA pressures upwards of 70 or 65 even, where I'm calling my ICU team, the ECMO team, just to say, hey, we need to have you on standby just in case we need to cannulate before or up front even. And we've had really good outcomes actually doing that. So I think if you're nervous about a case, and I think that the echo is a really key part of this. CT scans, it can be a little bit deceiving in terms of RV strain or not, but an echo, you can tell if the RV is blown out and how high the pressures are, and you should, it just helps to prevent any surprises. So.
Okay. Ripal, same question, and how that risk stratification works towards what you're going to do in the cath lab, or even if you take them to the lab.
Yeah, so, specifically for the intermediate risk group, we tend to intervene on the majority of the intermediate high-risk group patients, and that's mainly driven by probably two things. One is we've, instituted this program now for many years, and in fact, as we're trying to enroll patients in PE track trial, for example, which randomizes patients to anticoagulation, we're actually getting pushed back the other way. Only anticoagulate this patient is just because it's been driven by years of success and very few complications, and patients are doing well. But really, at our institution, we really try to put everybody in a clinical trial, and so specifically for the intermediate high risk. The intermediate low risk PE patients, most of them we will anticoagulate alone. But one of the things, as we're training our residents and fellows, I always tell them, hey, listen, have you laid eyes on the patient? What do they look like? Maybe they're fine while they're sitting in bed at rest. But once we have them walking, and we do a walk test on everybody, or even when they're walking over to the bathroom, they become tachycardic, short of breath, DSAT. These are patients that might be at risk of decompensation, and those are patients that we'll consider treating as well. Now, obviously, when we're looking at the high-risk patients, these are patients that have a very high mortality in the range of about 30%. So these patients, nobody's going to argue that they need treatment. In terms of what is the right treatment, I think it's something that is still debated. But, we tend to risk stratify these patients into what I would consider be catastrophic high risk. These are patients that are dying in front of you, and if they don't have any contraindications, we'll give them TPA. And then we have the so-called, stable high-risk patients. Maybe they're on one pressor, but they're doing okay. They look fine. And these are patients that we'll seriously consider bringing to the lab for a large bore mechanical thrombectomy.
Gotcha. Kind of like one of the questions that I feel like always comes up in this topic, timing of when you take your patient to the cath lab. Zarina, I know there are a couple patient populations to go over, but talk about the acuity of managing PE and then when you end up in the lab for patients you are going to take to the lab.
Mm-hmm. Generally, I like to, sorry to be the annoying interventional cardiologist, but I like to sort of compare it to ACS patients. And I like to kind of think of these people as like a high-risk NSTEMI where they're going to, not even high risk, I would say an NSTEMI, where they're probably going to need to go within the next 24 hours. So that's kind of my rule of thumb. Now, if you have somebody who's going to decompensate overnight, you definitely should go in and do it. But generally, I try to tackle these 24 hours at the most 48 hours out.
Okay. Ripal, same question?
Yeah, very similar. Look at the high-risk patients, we're going to treat right away. And most of the intermediate risk patients will watch, but you could see, a patient who has elevated lactic acid, and these patients are at high risk of decompensation. We know that about a third of patients with intermediate risk PE are actually in shock if you look at the cardiac index, being less than 2.2. Now, unfortunately, we don't have a great way of identifying those patients. We really have to look at the patient in sum. But if I see a patient who's tachycardic with elevated lactic acid, these are patients that I will probably not going to feel comfortable sitting on. Or if their vitals are kind of borderline, while they're not technically high risk, but their vitals are on the borderline side, these are patients I might choose to bring, immediately in the middle of the night as necessary.
Okay, gotcha. So I want to talk about just shifting gears a little bit to the topic and maybe the some of the meat of it is the actual procedure. And I was going to break it up into a couple different categories, but the first part that I wanted to tackle is procedure, but just take me up to the point to where you get your catheters or your devices into the pulmonary arteries. And Ripal, we can start with you.
Yeah, so I mean, obviously, after we choose that we're going to choose to intervene on one of these patients, ideally I'd like to have a lower extremity duplex examination. If I don't, we'll do an ultrasound on the table. Obviously, I don't want to puncture the side where there might be a DVT in place. And obviously, we'll go ahead and puncture the other side. Obviously, every patient will get an EKG beforehand. And any patient who might have a left bundle branch block, these are patients that we really have to look at seriously. They might require a pacemaker prior to the procedure to prevent any type of injury. At that point in time, we'll get venous access. We typically will put in a 5 or 6 French sheath. And the next thing we will do is we'll do a venogram in every single patient. Basically from our access site all the way up to the right atrium to make sure that there's no large clot that, we typically don't have a scan down there other than an ultrasound. It might be difficult to identify a large, caval clot, for example, that you might have to deal with on your way up. At that point in time, we'll catheterize the pulmonary artery, and we could either utilize either an angled pigtail catheter or a balloon-tipped, swan-type catheter, which has a wire lumen. And we kind of have, variances, or just differences within our practice amongst, who likes a pigtail versus a swan, but they both work. And as soon as we catheterize the pulmonary artery, at that point, the first thing that we do is we check a pulmonary artery pressure. And, when we're looking at PA pressures that are over 70 millimeters mercury, those are patients with severe pulmonary hypertension, and that are not necessarily a contraindication for doing thrombectomy. But the point here is that some of these patients may have a chronic component, and they may not benefit to the same degree. However, that is not a contraindication to doing a thrombectomy. At that point, we're typically looking at the CTA, in detail. We already know where our thrombus is to begin with. And I used to do angiograms in a lot of these patients. And a lot of times I did the angiograms more for myself. When these patients that are sicker, honestly, I don't even do an angiogram anymore. I will take a pigtail catheter, push it as far as it'll go, take a 1 centimeter tip Amplatz guide wire, and I let it kind of loop back on itself in the pulmonary artery. At that point, I pull out my pigtail. I use serial dilators up to 24 French, put in the Intri 24 sheath. Subsequently, I go with the T24 FlowTriever catheter every single time. And most of the time these days, this is without having done a single pulmonary angiogram. You just take the catheter up to where you think that the clot is and just start doing aspiration. And it's extremely effective. The device is large and is very powerful in removing thrombus. And it doesn't just take out the thrombus in the central pulmonary arteries. It often will pull, it's so powerful that it will grab some of the thrombus into, it's not going to grab every little subsegmental thrombus.
Sure.
I don't want to mislead anybody, but it will often grab some of the more distal thrombus as well. Typically, that's my go-to for my right side, for my right pulmonary artery. For the left pulmonary artery, I've gone to utilizing a T20 curve as my go-to device in every case. In fact, I just open it up at the beginning of the case, provided that there's left-sided pulmonary embolism as well. And we basically, pull the wire back. The D24 typically just flips into the left side, catheterize the left pulmonary artery as well. Sometimes utilizing an ipsilateral oblique there can be helpful. When you look at AP projection, you're a little bit deceived. You're looking at the curve. You say, can I advance this device over that curve? But if you do a little bit of oblique, you realize it's not as steep of a curve as you think. And you take a T20 curve into the left pulmonary artery and do a thrombectomy there as well. And that's typically, all you need. I mean, there's, some nuances there, which we can get into a little more detail, but that's, a typical procedure. When I feel like I'm done, which is really on the basis of looking at the pulmonary angiographic appearance. Number 2, seeing a drop in the pulmonary artery pressures. And number 3, if their vitals were abnormal to begin with, seeing an improvement in their vitals. At that point, utilizing kind of a combination of those 3 factors will be, hey, at this point, I feel like I'm done. And they'll, call it a day at that point in time. Usually just managing the access site with just manual compression alone, with or without a flow stasis device. Sometimes we'll utilize a suture as well. I typically don't pre-close the vein. Now, some people are concerned about a 24 French hole, but honestly, the number of times that we've had a groin hematoma are pretty low, and I never stop the anticoagulation.
Got it. All right. Well said. Zarina, same question. Just want to know how you do your procedure. And then I'm actually going to pepper in after you get done with a couple more pointed questions about why you guys use and what you're doing.
Yeah, a lot of similarities actually to Dr. Gandhi, but basically I generally prefer right femoral vein. It's such a straight shot up to the IVC in the right heart. I usually actually pre-close my access just with one pre-close up front because I just find that it's very effective for hemostasis at the end, and that's all you need. But I, at that point, start with my right heart cath. I get pressures on the way in, RA, RV. I usually do an angled peg and a Rosen wire. Sometimes if the RV is large, I mean, and I know everybody's had these cases where that can sometimes be the longest part of the case to get up there into the PA, let alone tracking your 24 French catheter up there. But it usually takes a combination of sometimes trying a JR or a multi-purpose, like just different types of catheters and different wires to actually get up there. I also usually go to the right side straight away. I don't usually bother doing an angio up front, but do the thrombectomy. Left-sided, most often I'm having to use the T20 curve to just get down there adequately. But yeah, that's pretty much it.
So, Zarina, I'll ask you, why are you guys using an angled pig or like a balloon-assisted catheter to get up? Just to let some of, like if you don't do a lot of these, you're not in the pulmonary arteries very often.
Yeah, I mean, I just find that especially in the patients who have larger RVs, I feel like the angled pig it's just anatomically, it's more suited to just track up the RVOT into the PA. And balloon tips, I mean, if you're familiar with floating swans, I mean, it's just easiest to have a balloon tip catheter. It just seems to track a little bit more easily up there.
Okay. So Zarina, with you, once you have your Rosen in, will the 24 French catheter track over that, or do you exchange out for the Amplats?
This is a good question. I've tried both ways and kicked myself a few times in the case when I use a Rosen. But generally, I honestly sort of gauge by the patient's body habitus and how easy it was to track my equipment up there in the first place. So if I find that it's a larger patient or the RV is huge and I'm going to need support, I'll just switch out to Amplats instead of the Rosen. But I have done cases where I just upsize over the Rosen and it's fine. I
just wanted to add something to what Zarina said in terms of, the pigtail versus a swan catheter. For people who haven't done these catheters, the key and the reason to utilize these catheters is if you accidentally get behind the chordae. You're taking a 24 French device up there, you're going to tear it and you're going to have a problem. So yeah, while you could get away with it with, smaller profile devices, that's really critical to somebody who's never done this procedure. And I've had cases, like Zarina described, where you have a really blown out heart and your heart have a hard time getting anything up there. And I sometimes just utilize like a MPA catheter or some type of angled catheter to get up there. But before I start advancing a device there, I will always run a balloon over that wire. And I want to make sure that thing is flowing, completely smoothly without any interruption. It should smoothly go up, smoothly come back. And then you're not behind a valve. Otherwise, you're going to end up with major complications.
Right. And so, Ripal, so if you end up like in between a chordae or like you catch a valve and like you run that balloon up, like what size balloon are you using? Like any real like examples of what you like off the shelf? Like is a Fogarty big enough or do you need like a Python?
Yeah, just a 035 over the wire Fogarty works perfectly fine. Or the Swan that we utilize, the Arrow Swan. You could just run, the Arrow Swan has an 035 lumen to it. So you could just run that right over your wire as well.
Okay. Ripal, you also mentioned that during the workup, all your patients get an EKG, and you specifically mentioned left bundle branch block. Can you just like dumb it down, like why this in particular you're worried about?
Yeah, sure. I think, sometimes, when you're caught in the excitement of, or, a sick patient, it's easy to forget some of the most important critical things, when you're doing one of these procedures. This is something you don't want to miss. Because if you have a left bundle branch block and just crossing the right heart, you can induce a right bundle branch block and the patient will go into a total heart block. And the last thing you want to be dealing with, especially if it's in the middle of the night, is, a patient with a complete heart block who's already sick. So again, look, if you already know it in advance, you could plan for it and, get a pacemaker, etc. But if you missed that to begin with, you could run into major issues. And I think, Zarina can probably speak on this, in much more detail as a cardiologist, but it's something that I don't want to be dealing with in the middle of the night.
Sure. All right. So one of the things that I wanted to talk about is just best practices. Like you both of you start on the right. Any reason you start on the right, or is that just where the 24 French finds itself? Zarina, start with you.
I think kind of as Dr. Gandhi was talking about earlier, like it's basically, I start on the right because I find after you do that, it's just easy to swing over to the left and get onto that side. Yeah.
Okay. And as far as like you guys both mentioned using the T20 catheter and the curve of that, so what you do is while you're in the right, you have the T20 up and you just pull back and twist and it'll just fall into the left. Okay. I guess what I'm trying to get at, is there anything that you guys have learned with these devices or like this set of tools? I guess like any kind of illustrative points, like learning, like growing pains along the way. That's like, oh, this is a trick that I learned that makes more sense. Or this is why I start with T24, then go T20 and not T16. I don't know. I'm just trying to uncover any gems. Like you would be surprised like how much you guys like have built-in knowledge. I'm trying to see if there's anything like you guys learned along the way and like, this is how you do it now. Ripal, we can start with you.
Sure. I mean, some basic things. Number one, look, I think a large bore catheter is needed for large thrombus removal. So for that reason, I like to go with the T24 every time. And it's surprising how much clot you can get out with that. Couple things, when you're pulling back on the syringe, if you've never utilized the device, if you see free flowing blood, that means you're not on clot. So at that point, you want to reposition the catheter. That's obvious. If you pull it back, and you get very little, you're getting a little bit of anything, or you get kind of a little bit of a slow fill. That point we'll do what's called a double. So basically you just disconnect it and basically do a second aspiration on there. And that will and at that point, if you're getting kind of the same thing, then you slowly pull the catheter back. You might be on a really big clot, or you might be against the wall of the vessel, and you slowly pull it back until you get a lot of clot out. Or if you're getting nothing out, then you have something called a lollipop, where you can imagine you have a giant thrombus, which is kind of partially ingested by the device. And the only way to really get that out is to drag the entire catheter out of the body. And you want to make sure that, you'll get this giant clot, sitting inside your catheter. On the left side, before we had the T20 curve, we were using the T24 and just the angle of the left pulmonary artery, the catheter would you end up aspirating right on the wall of the left pulmonary artery. So the T20 curve really prevents you from doing that. You can get it much deeper engaged into the left pulmonary artery, and it really does work. You basically can aspirate a large amount of clot, and sometimes you'll basically be in a very similar situation where you've aspirated and you're getting there's nothing that's coming back. Maybe you have a big clot engaged on it, and what I would recommend in that situation is as you pull it back and you get up to the T24, now do a simultaneous aspiration on the T24 at the same time as your T20. So, and then if you need to, you could pull both of the catheters back. One final thing I would add is looking at the truncus anterior. That could be sometimes a little bit challenging, and utilizing a double wire technique can be extremely helpful there. So basically what you leave up, typically for me, it's a 1 centimeter tip Amplatz wire. I have it sitting somewhere in the right pulmonary artery. And at that point in time, I pull the catheter back when it is sitting up there on the truncus anterior. Take a second catheter with a guide wire to select the TA. And then at that point only do I give up the buddy wire and then utilize a dilator to advance. You really don't have to get into it very far. Just get into kind of the origin a little bit past that and do an aspiration there as well. And that could be a very useful technique.
Okay. Zarina, any other techniques or advice you want to paint on?
Yeah, I think early on I used to be very sort of OCD about, the PA pressure pre and post. In my opinion, I think what I would love to see each case is a 50% drop in your PA systolic pressure, and I feel good about that. But it's not necessarily that you're going to get that every time, and I think that that's okay. If you see other clinical indicators that the patient is improved, their O2 sats, their oxygen levels have dramatically, how much they're requiring has come down, their heart rate's coming down, they feel just like their breathing is better. I think that these are all things that you should look at, not just the PA pressure as a sign of success. And then on the angiogram too, I used to get really frustrated in terms of just like how to get a good angiogram and I think it honestly comes down to a lot of how much sedation you give the patient, because obviously if you're trying to take an angiogram and the patient's moving, you're going to just get crap quality images. So I think making sure that you sort of coach the patient through that so that you get a nice angio at the end is a good idea. And even if you have small residual thrombus that's more distal, I used to kind of obsess over it, but if you have other clinical indicators that say that you've made a difference, I just usually leave that.
Okay, so that was actually my next question. So when do you call it good, your endpoint, how much clot do you have to get out, and not how distal do you have to go, but Zarina, you kind of answered it with the clinical picture kind of dictates it. Ripal, do you have any other color commentary on endpoint?
Yeah, I mean, it's something that we always struggle with, when are we done? As I mentioned earlier, I'm really looking at three things. Again, the most important thing is the patient who's hemodynamically not doing well. If they get better, that to me is the most important thing. But a lot of these intermediate risk patients, maybe they'll be a little tachycardic, but otherwise they're normotensive, they're satting okay. So you can't always utilize that as a clinical endpoint. But if you can use it, I think it's the most valuable thing. The other two things I'm looking for is obviously the angiographic appearance and a drop in the systolic pressures and the PA pressures. And it's something that we measure every single time. And it's something that, maybe in the future we could start looking at cardiac index, but it's a little bit harder to do kind of real time. But those are the three measures that we're looking at.
Okay. What specific clinical scenarios make the FlowTriever the ideal choice for y'all's PE patients, like particularly those that have elevated PA pressures? Ripal, keep going.
Yeah. So, it was one of the questions and concerns that I had, a few years ago. For anybody who's never utilized this catheter, I could tell you the very first time I utilized it, I remember thinking, gosh, I'm taking a 24 French, garden hose and I'm putting it into the pulmonary arteries. Is that safe? And is it trackable? And I could tell you, having done a lot of these cases, number one, it's very safe, and number two, it's very trackable. But my next question was, is it safe to do this in patients with severe pulmonary hypertension? Are these patients going to go into sudden cardiac arrest and die on me? And I like to be as data driven as I can be. And the only data that I've seen for this group of patients was from the FLASH registry, where there was I think there's about 99 or almost 100 patients who actually had elevated PA pressures greater than 70 millimeters mercury. And if you looked at their outcomes and their adverse events, they were exactly the same as those patients who did not have severe pulmonary hypertension. So, I don't utilize that as an exclusion factor at all. This is something that I will treat anybody with elevated PA pressure with the understanding that they probably have some chronic pulmonary hypertension, and I might not get the same results as I would in somebody without severe pulmonary hypertension.
All right, Zarina, same question. I'm getting at, what specific clinical scenarios do you like about the FlowTriever and it being the choice for your PE patients? And then, particularly the patient population that's thinking about those with elevated PA pressures.
Okay. Yeah, I think if you have a patient with a lot of thrombus, and I think as proceduralists, we're always looking for the most effective device that can get the job done the quickest. And this is truly that device because of how much thrombus you can remove even just with one pull. I've had cases where I do one pull on the right, one pull on the left, and you're done because it's just that effective in thrombus removal. So this is just basically my go-to device for intermediate risk PEs.
Have either one of you guys used catheter-directed thrombolysis? Was that ever, Zarina, I know that you said you were 2 years out. Did you ever start with that?
I never did, actually. There are partners in my group that have used it and still continue to use it, but I never actually have.
So Ripal, maybe a question for you. I was wondering, catheter-directed, your experience with catheter-directed thrombolysis versus, mechanical thrombectomy. I'm thinking ICU stays, having to drip lytics, bleeding risks of having to drip those lytics. Can you compare a little bit?
Sure. Look, I've been doing this for some time now, and all we had, other than, some catheters which were not really purpose-driven for pulmonary embolism treatment, was catheter-directed lysis. And truth be told, until now, the only randomized clinical trial, even though it was a very small trial, was with catheter-directed lysis, was the ultimate trial, which was only 60 patients. And what we've learned, kind of from our experience and so forth is, look, catheter-directed lysis, if it's done appropriately, it can be done safely. However, there are issues. Number one, bleeding risks. At least a third of our patients have some type of contraindication to thrombolysis. So that poses a problem in itself. Number two, you have a patient who's very sick. Catheter-directed thrombolysis takes some time for it to work. So oftentimes you don't have that time. That patient needs to be treated immediately. Otherwise, they're going to go in a downward death spiral. And those are patients in whom catheter-directed thrombolysis may not work. But I could tell you, if you were to ask me about 10 years ago, majority of our patients got catheter-directed thrombolysis, period. Now it's almost, 95% of our patients get mechanical thrombectomy. There's still a small proportion of patients who will still get catheter-directed thrombolysis. Those are typically patients, the rare patients, probably less than 5%, where they have right heart strain, but majority of their thrombus is kind of in the mid to distal pulmonary arteries where possibly catheter-directed lysis has a better result.
Okay. So now, taking a little bit of a left turn, I just want to get into the data. And Zarina, we can start with you, but can you describe the study and, well, just first, just kind of overview, tell us about the study.
Yeah, so basically, Peerless is a trial that I think that there's been sort of a dearth of data for the last 10 years, but Peerless is truly the first trial that has looked at 2 interventional techniques to treat intermediate risk patients. So these are truly patients that are not hypotensive. They're intermediate risk. They've had symptoms for less than 2 weeks. And so they are basically comparing catheter-directed thrombolysis to mechanical thrombectomy using the FlowTriever system. And there's been a lot of people out there who are like, well, why is there not a third group looking at anticoagulation in comparison to one of these 2? And I think that truly they just wanted to compare the 2 interventional techniques on the market right now. And so that's what this trial is about. And so basically they followed these patients, I think it was about 550 patients total, and they followed them over the course of about 30 days or so. And basically looked at a series of outcomes, but all of them were sort of described in what we call this win ratio, which included about 5 different things, including ICU length of stay, total hospitalization, but it was basically a win for mechanical thrombectomy, and it showed superiority over catheter-directed lysis.
I have a couple of follow-up questions, but I'll just leave it like a broad question for Ripal, then I'll come back to them. Ripal, so anything else like what the study told us? Like what was your big takeaway from Peerless?
Yeah, so again, if you look at the win ratio, which looked at really 5 factors, which was basically mortality, intracranial hemorrhage, major bleeding, clinical deterioration or bailout, and ICU length of stay. And it was a big win, as Zarina stated. It was basically a win ratio of 5, which is very significant, and that was obviously statistically significant. But if I were to just give you the kind of the big takeaways, number 1, patients got better faster. If you looked at how they're feeling, if you looked at several parameters in terms of hemodynamics or their RV function at 24 hours, they were all improved. So patients were doing better, and they got better faster. Number 2, there were few patients who had clinical deteriorations and bailouts. In fact, it was 3-fold higher in the catheter-directed thrombolysis arm versus FlowTriever, which is very significant. Having to bail out 3 times as number of patients is a big deal. And in fact, if you looked at that in a little bit more detail, and you looked at the patients who actually required bailout with catheter-directed thrombolysis, these were patients who ended up having cardiac arrest, respiratory failure, which resulted in intubation, or heart block requiring a pacemaker. And they didn't occur at the time of the procedure, they occurred after the procedure. Whereas the deteriorations that occurred with FlowTriever actually happened at the time of the procedure, which is what I want. I want to be able to deal with it immediately. Other big takeaways were less ICU length of stay, 1 day less hospitalization overall, and then readmission rates were decreased by 60%. And all of this was done in the context of extremely excellent safety profile with a large bore thrombectomy device. So to me, this really kind of changes the standard of care for patients that we choose to intervene on with intermediate high-risk pulmonary embolism.
I don't know if either one of you guys had insight as to why the study was designed like it was, but one of my thoughts was, so Peerless 2 is supposed to look at mechanical thrombectomy versus anticoagulation alone. But the reason that maybe Inari chose 2 interventional procedures is because right now the guidelines would actually suggest that we should be using more catheter-directed thrombolysis. Am I off on that, or?
I don't know. I wasn't involved. I wasn't part of the steering committee in terms of how this study was designed. But this is what the way I would see it. For a patient that actually you decide that you need to intervene upon, it was not very clear. Which device is better, and we don't know, or we didn't know up to this point in time. And if you looked at if you look at clinical deterioration at about a week, it's about 5% of patients. You get about almost a 2% mortality at a week. And if you take it out to 30 days, about 1 in 10 patients die. So for the patients that you've already made a decision, hey, you're going to be doing an intervention, this really guides us, hey, this is probably the right way to go. But we still need the data versus anticoagulation. And I completely agree with you there.
Okay. Zarina, a slightly different question, but similar, and I think Ripal's kind of answered it. But what parts of the Peerless data kind of resonated with you as if I'm going to intervene on patients, this is where I want to be?
Mm-hmm. I mean, I think that the data on symptom improvement was pretty striking. I think it's great to see when we're able to do a procedure that results in immediate patient symptom improvement. And that was sort of evidenced in this trial by they used the NYHA class scoring system, and they reported basically those who had NYHA class 3 or 4 symptoms was 27% in the CDT group versus 16% in the thrombectomy group. So pretty marked difference. And then I think as a cardiologist, one of the biggest ways that we assess the hemodynamic significance of something that we've done intervention-wise is look at the echo and look at the right heart function. And so it was nice to see that moderate to severe RV dysfunction was not as common in the thrombectomy group compared to the CDT group. And I think it's only going to be more eye-opening to see the more long-term results, because naturally at the end of the day, the thing that we worry about with PE patients is CTEPH and the results of having thrombus there for a long period of time over the years and what that can do to the lungs. So,
okay. Ripal or Zarina, as far as like the questions I asked about the Peerless data, did I not ask anything that's important or anything that stuck out to you that like a stone left unturned with regarding to the data?
I think two of the things that, I've gotten a lot of questions about is number one, mortality, and number two is bleeding risk. And, number one is, why was there no difference in mortality? Number one, the mortality risk is not that high in this patient population to begin with. But number two, this study was not powered to look at mortality differences. Furthermore, of the 6 patients who had bailout in the catheter-directed thrombolysis arm, 5 of them were actually bailed out with a flow retriever thrombectomy. And if that was not allowed, some of these patients had cardiac arrest, intubation with respiratory failure, or complete heart block, or AV block. If we didn't bail these patients out, some of those patients might have died and there might have been a difference in mortality. And then the second thing was bleeding, which I actually was surprised by as well until I looked at the data in a little bit more detail. I thought the patients with catheter-directed thrombolysis would have a higher bleeding risk. However, if you looked at the study in a little bit more detail, only 4% of the patient population was actually had a relative contraindication to thrombolysis. So this was a very low risk patient population for bleeding to begin with. And as a site in the study, I could tell you that there was a bunch of criteria for contraindications. And then there was also something that said investigator's judgment. And I could tell you, if you had a patient, we've had many patients like this where they kind of had metastatic disease, there was no brain mets. We just chose not to enroll those patients. They were put into this contraindication arm. So yes, I think if you were to enroll patients in a real world population where about a third of patients have a contraindication of thrombolysis, I think you're going to see increased bleeding risk with catheter-directed lysis for sure. But for this patient with a low bleeding risk to begin with, that's why the bleeding risk was not different between the two groups.
All right, well said. Zarina, anything to paint on top of that?
No.
So Ripal, BackTable loyalists may remember a story that I thought you could share, but it's basically about a patient experience with a patient who was an interventional radiologist that you had to intervene on. I was curious if you give us a little color commentary as to like how that experience was and like kind of share what the patient experience is like undergoing the procedure.
Sure, Chris. This is, there's no HIPAA violation here as he was on the podcast.
No, he was on the podcast. I mean, so you can, and we'll link to it. We'll link to the show, but go ahead.
So this is a good friend of mine, Ilan Riole, who's in fact one of my closest friends. He was doing flow retriever thrombectomy actually much prior to, much before I was. And he was one who actually, told me, hey, like, you got to try this. And he kept showing me all these pictures. It was something that I really wanted to try. But we'd often talk about, difficult cases, etc. And he called me one afternoon. I remember very clearly. It was a Wednesday, probably early afternoon. And he's like, I have a PE. And I'm like, oh, tell me about the patient. And he goes, no, I have a PE. And I really thought he was joking around at the time. And he sent me, he basically, told me he woke up that morning, wasn't feeling great, but decided to go to work anyway. And actually his nurse, who actually was my nurse way back in the day, who I know very well, kind of forced him to go to the ER. And, he had pretty significant, pulmonary embolism, had all elevated biomarkers, large clot burden. He sent me the scan, on the phone. And I'm like, and he said, hey, listen, I want you to treat me. And of course, there was no hesitation there. And we finally had him, sent to our hospital, we treated him that evening. And of course, there was no hesitation at all. But of course, when you're treating, one of your closest friends, in the back of my mind, I'm like, gosh, if something bad happens here, I have to tell you, I was scared. I didn't tell him that until way after the fact when we had dinner, months later. But we went in there. Of course, when you're trying to treat your friend, things don't go as smoothly as possible. The wire went somewhere where I wasn't sure where it was, and maybe it went through an ASD or PFO. I rewired him, finally put a catheter up there, and I checked his pressures, and they were over 80. And I couldn't believe it. And I was like, there's something wrong here. Re-zero the lines. Still over 80. I'm like, get somebody from another room. Get some new equipment, because I still don't believe it. And it was really that high. And I'm like, all right, we're here. And actually, one of the things I forgot to mention in there was actually we were enrolling patients in the Peerless trial at that time. So when he came over, I'm like, listen, dude, I gotta ask you, do you want to be a participant in the trial? He goes, no. I want flow treatment. That's why I'm here. I'm like, all right, listen, I had to ask. But anyway, the pressures were high. I had a little hesitation, but we put the catheters up there. We got a lot of clot out. And that's at one point in the procedure, we had these like slave monitors that, I wasn't really paying attention, but the nurse had put one of the slave monitors right in front of him because he wanted, we do these procedures with the patient awake. We use a lot of local. Maybe I'll use a touch of anxiolysis if the patient is really not feeling well. But he's watching this whole thing, and at one point he goes, that was great. They're like, you're watching this? So anyway, I got to a point where, I felt like I was done, and I'm like, hey, what do you think? Do you want me to do any more? He goes, no, and we're done. Everything went great. And I hooked him up with our co-director of our PERT team, who's an amazing cardiologist who, followed him up. And his pressure is completely normalized. So yes, we have this, I think it's generally true that patients with severe pulmonary hypertension have element of chronic pulmonary hypertension, but I can't really describe it in him. But he completely normalized, is doing great. But like I said, months later, it was probably maybe 6 months later, we're out to dinner, and I'm like, man, I was scared. I was like, look, I do this every day, but treating you is a completely different thing. But I'm glad it went well.
Me also. I was just sweating, thinking about having to treat one of my partners, and even just treating other physicians. It's when you want it to go perfectly. Those are the cases that don't go perfectly, and for me, I also end up in my head for a lot of those cases too. So kudos for you. And for the BackTable audience, if you guys want to hear the other side of that story, I'll link to it in the show notes. I think it is episode, I wrote it down, 419. Don't quote me on it, but we'll link to it in the show notes. Zarina, a question for you. You've championed personalized care for women's cardiovascular health. How do gender differences impact the way in which you treat PE for women?
Yeah, I think that women who present with PE can often be very young, and this is usually one of their first, if not their only encounter for them in the hospital. So it's a very sort of anxiety-provoking situation. Young women who present with PE are often either on birth control, or they're pregnant, or it just immediately postpartum. So obviously pregnancy can present a very big challenge to managing intermediate or high-risk PE, with the radiation concern, of course. But we have done a few of these cases in our group, and these women happen to be pregnant. It's definitely an uncomfortable situation to have to treat a pregnant patient with PE, but they have done well. And at the end of the day, you have to prioritize the mom's health. So
yeah, treating mom in this situation is best for mom and baby, I would assume.
Yes, exactly.
So I have a couple closing questions, and we'll try and blow through these so we can do some case show. Takeaway lessons from the Peerless data to improve collaboration between cardiology and interventional radiology and maybe other departments and PE treatments. Thoughts, Zarina?
I think that it's just really important, given this data that's come out, in terms of educating all providers about the importance of being aggressive enough in certain situations. Anticoagulation is not necessarily the best way to go. And now I think that we have data showing that catheter-directed lysis is not necessarily the way to go. And I think that when a PE patient comes into a certain hospital, a lot of times, as unfortunate as it might be, their care is dictated by who's on call that day. And so I think it's really important to educate all interventionalists on how to do thrombectomy, because we do have a trial now showing that it is superior and does offer better outcomes for patients.
Next question, Ripal. As far as the future of PE treatment, what's the most exciting thing that when you think about the future of PE treatment that comes to mind?
Yeah, really getting into kind of the golden age of randomized clinical trials for PE. So this is where we really need to be. And there are at least 4 randomized clinical trials that I'm aware of right now that are specifically comparing some type of catheter-based intervention versus anticoagulation alone. And, look, we're, for a lot of us, we're believers, but when we're talking to some of our colleagues and, whether it be pulmonology or critical care or ER or hospitalists, et cetera, a lot of their questions, legitimately so, are, how does this compare to anticoagulation alone for patients with intermediate risk PE? And we don't have that answer yet. While, I certainly believe in it. We really need the data to support that. And in the next few years, we're going to have legitimate, well-conducted randomized clinical trials to answer this question. So, stay tuned.
All right. Last question. Advice for those new to pulmonary embolus interventions. Zarina?
I would say for interventional cardiologists, I think especially those, and a lot of fellows now are being trained in structural interventions. Whether or not there's jobs out there for structural cardiologists is another question, but I think it's very easy to make that transition from being an interventional/structural cardiologist to doing thrombectomy because it's large bore access. We're oftentimes doing this for TAVR or impella placements and things like that, and it's venous, which makes it a lot less high risk, in my opinion. So I think that it's just one of those things to add to your toolkit and to make you a much more well-rounded interventionalist to be in the PE space.
Yeah, I would imagine that the PE space has got to be way more forgiving than doing a TAVR.
Oh, yeah.
Okay.
Yeah, definitely.
Having never done one. All right, Ripal, same question to you. Any advice for those new to the pulmonary embolism space?
I could tell you this is, like I mentioned earlier, this is probably one of the most gratifying things that we do. Look, there's a lot of procedures that we do are life-saving, including, treating ruptured aortic aneurysm, treating patients, with severe trauma, massive GI bleeding. And this is another one that really kind of fits well into our skills and our toolbox. And I would encourage anybody who's really interested to really get involved because, yes, you're going to be dealing with very sick patients. You might be doing procedures in the middle of the night. You might have patients who die, on your table, yet it is one of the most gratifying things that we do. You take a patient who's really sick and save their lives, and you're literally seeing an improvement in their vitals, their hemodynamics, and how well they're feeling after the procedure. There's nothing like it.
Okay. Zarina, similar question, and you spoke to it a little bit, but these procedures are kind of fun, right? Like sucking out a big bunch of clot and
it's
seeing
very
all
gratifying.
that.
Yeah.
Okay.
I'm usually giving the rep a little bit of crap if we don't see a big blood clot sitting on the back table at the end.
That's right. All right. I think if you guys are ready, let's do some case shows, case presentations. Zarina, do you want to start with yours?
So I think this case really sort of exemplifies a lot of this thought process that we've discussed pretty well. So this is the case of a 44-year-old guy, history of diabetes, who came in with about a week of shortness of breath. And when he came to the ER, these were his presenting vitals. He was on 3 liters, sats in the mid-90s, a little bit tachycardic there with stable blood pressure. And you can see his cardiac enzymes are elevated. Creatinine was 2.1. We did not have a lactate at that point. So he was admitted to the PCU. And I was called with this CTA. And so you can see here he has quite a significant clot burden, saddle PE there with a lot of proximal thrombus on both the right and the left. And if you look at his right heart, which we'll scroll through here in a minute, you can see that it is definitely dilated. So about an hour later after he was admitted to the PCU, and I'll say that this was actually at one of our smaller community hospitals, his vitals drastically changed. His oxygen requirement went up and became quite a bit more tachycardic with soft blood pressure, and his lactate did come back at 6. So at that point, I knew that I had to do something. And because this guy was sort of rapidly decompensating, I said, let's just go ahead and transfer him to our main hospital, which was done pretty rapidly. And we took him within an hour to the cath lab. And so we went ahead and we did thrombectomy, kind of the usual process. This was after we had already done the right side, and this was our final shot on the left. But this was the final clot that we were able to remove. And up at the top, as we were talking about with the PA pressures, he started out with PA pressures in the 50s and, sort of a modest drop despite all that clot that we got out into the mid-40s, PA systolic afterwards. So, but in his case, his heart rate went from the 130s down to the hundreds afterwards. And he was basically 100% on just a few liters by the end of it. So I think that this is something that I was also alluding to earlier, but this was his echo the day after. And not a great RV picture, but you can see that the RV is mildly dilated, mild to moderately reduced function-wise. And his RV systolic pressure was actually normal based on the tricuspid signal that we got. So I think that when you talk about different options for treatment in this case, Anticoagulation clearly would not be enough here. Catheter-directed lysis, I think, would take quite a bit of time. And this patient just did not have time when it came to that amount of clot burden and how rapidly he was deteriorating. TPA, I always get very hesitant to use TPA, especially in a young person, honestly, anybody. But I just felt that it was overly aggressive and just not something that he qualified for because his pressure was soft but not hypotensive. So I say that thrombectomy is truly the perfect therapy here. You quickly debulk the clot, improve oxygenation, and you can prevent hemodynamic collapse. So just a quick case there.
If you happen to remember, like, how long did it take you? I mean, not to catheterize everything, but just like once you start like running the FlowTriever, how long before you've cleared the right, cleared the left?
That whole case actually took about an hour.
Not bad. Okay.
Yeah, so not too bad. Yeah.
Ripal, you want to see if we can switch over to you?
So I'm going to go to the presentation here. This is a 44-year-old gentleman who was actually transferred to our hospital from an outside facility after he had 2 syncopal episodes and had 1 week of dyspnea. The main risk factor was he had recent travel to Bahamas. And interestingly, he was kind of misdiagnosed at the other hospital. He had elevated troponins, and they thought he was having an NSTEMI. He was given aspirin, low pressor, and heparin prior to the transfer. Here's the patient's vitals. You can see his tachycardic, respiratory rate is elevated, although he is normotensive. Satting 96% on 2 liters of oxygen. He has elevated biomarkers, as you can see. Lactic acid is kind of borderline. It's not, truly increased, but we're getting up there. You can see the CT pulmonary angiogram here to the right with a saddle pulmonary embolism, significant central pulmonary emboli, and an elevated RV to LV ratio here. This is just some coronal images kind of looking at the same thing here. You see RV-LV ratio here being 1.5. S-PESI score is 1. So again, this patient has an intermediate high-risk pulmonary embolism, given evidence of imaging signs of right heart strain and elevated biomarkers. Also had a composite PE shock score of 5. And everybody might not be familiar with that score per se. So just as a quick review, it basically consists of these 6 components here, which are listed here, and each one of these gets 1 point. RV dysfunction, elevated troponins, increased pro-BNP, residual DVT, central PE, as well as tachycardia. And, this composite pulmonary embolism shock score has previously been shown to be associated with normotensive shock. However, what they found in this study was if you had a score of 3 or greater, patients had an increased risk of mortality, resuscitated cardiac arrest, and decompensation compared to a low CPES score. And I think this what allows us to do is sometimes we struggle with some of these patients, which patient should we treat or not. And this allows us to further kind of risk stratify the patient with intermediate risk PE and help prognosticate patients who might have a worse outcome. So it might be something that you might want to consider utilizing in your own practice.
How do you guys view this? If you see a patient with 3 or higher, that means like you automatically stratify them into intermediate high risk and they go to the cath lab, or?
Yeah, so again, the intermediate high risk is really based on presence of imaging findings of right heart strain as well as elevated biomarkers. And in our center, most of these patients are going to the cath lab, and we try to enroll patients and almost all those patients in a clinical trial if they're willing. But you sometimes get these patients where it's not very clear, or maybe they're intermediate low risk, but they don't look great. And these are the patients that you could further risk stratify them by utilizing this score. It's just another way to further risk stratify these patients.
Okay, I got you.
So we got again, a patient had a left lower extremity venous, had left lower extremity DVT. Echo showed pretty much what we were expecting. This patient had dilated RV with a decreased RV function. He had positive McConnell sign. Estimated RV systolic pressure was 38. So this patient was actually enrolled in the Peerless trial. Very pertinent to the discussion here. And as we talked about before, primary endpoint was looking at this win ratio of all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration, ICU admission, and length of stay. And basically, you just had to have a proximal pulmonary embolism with evidence of right heart strain of 14 days or less. And this is exactly what this patient had. So again, the inclusion criteria again listed here. But in order to, in this trial, we wanted to try to get the patients which were maybe at a little bit higher risk. So they had to have one of the factors listed here. And this patient actually had several of them. He had elevated troponins, He was tachycardic, and he had a syncopal episode prior to arriving to the ER. Again, this is not a lot of people will say, hey, look, patient had a syncopal episode. This is a massive PE or a high-risk PE. But when he actually presented to us, he was actually hemodynamically stable, and that was an inclusion criteria for the trial. So the patient was randomized to catheter-directed lysis, and we always like, as we mentioned, how we're doing these procedures, I always like to get access, get a venogram that goes all the way through the IVC, make sure that there's no clot on the way. We went up with the angle pigtail catheter, and you could see the pressures were, pretty elevated, higher than what we saw or we predicted on the echo, 55/17, mean of 30 here. Again, patients with severe pulmonary hypertension were actually excluded from the trial, but that's not a contraindication of utilizing the device, as we had mentioned earlier. We really wanted to kind of exclude patients with more chronic DVT. So this patient was treated with catheter-directed lysis, with ultrasound-assisted catheter-directed lysis. Standard protocol, we use 0.5 milligrams per catheter. The patient got about 20 milligrams total. I think the average TPA dose in the trial was about 16 milligrams. And there was no procedural complications. The patient did fine from this procedure. Here's a patient's post-procedural CTA that was a part of the protocol. And you can see there's still, while the saddle component is gone, there's pretty significant central clot burden still. The RV-LV ratio, still remains dilated. Again, just showing you kind of comparison pre and post, and the RV to LV ratio pre and post as well. Now, I don't want to be a radiologist and just make decisions on the basis of just imaging findings. If we're going to choose to intervene, do anything further, I really want to see how the patient's doing. So the clinical deterioration criteria were very well listed here, and this patient met several of these. He had persistently elevated heart rate. He actually became tachycardic up to 135 with walking and talking. And this guy, he's a 44-year-old guy. We know that he's going to have problems if we let him go home like this. He had residual dyspnea. He had inability to even walk to the bathroom. And, as I mentioned before, we like to walk all these patients. And this guy wasn't going to do well. He had persistent tachycardia, inadequate thrombus resolution, as I showed you on the scan, and persistent signs and symptoms of PE with lack of hemodynamic improvement. So this was a bailout. This was one of the bailouts that was as part of the Peerless trial. So this patient was brought back. I happened to be out this day, so one of my partners treated this patient. Here again, he's just putting up the catheter here. Tino Pena treated this patient. Put a catheter up here into the left pulmonary artery. Again, significant clot burden. Right pulmonary artery, again, significant clot burden. And this is just utilizing, again, 1 centimeter tip Amplatz guide wire, advancing the FlowTriever, the T24. You can see how well this thing tracks. It's a big catheter, but it tracks extremely well. And this is just kind of showing moving from the right to the left. You kind of pull the wire back, and the device just kind of falls into the left. And these are the post-treatment pulmonary angiograms. Again, it's not perfect, but again, marked improvement in the blood flow to both lungs. And this is some of the clot that he got out. There was marked improvement in the pulmonary artery perfusion. The vitals normalized. PA pressures normalized, or at least decreased. And the patient, and most importantly, all this is great, but his symptoms were gone. We were able to do a walk test. He was a new man, and he was actually very, very appreciative. He didn't like to have, having to have gone through 2 procedures, but it is what it is, and this is sometimes what we experience. So that was that. This is another case. This is a patient that I treated more recently. This was a 79-year-old woman who presented with 2 days of dyspnea on exertion, had some lightheadedness, and had a presyncopal episode. Patient did have a history of unprovoked PE 4 years ago. Her primary care physician actually stopped her anticoagulation 4 months ago, which I didn't think was unreasonable. Vitals were stable, although she did have some tachycardia here. And here's the patient CT pulmonary angiogram. You can see, again, a large central clot burden bilaterally, and there is an increased RV to LV ratio, again, signifying right heart strain. Right RV to LV ratio is 1.3. You can see the patient had elevated biomarkers as well. Both troponins and proBNP was elevated, although lactic acid was normal. Echo showed RV dilatation with decreased RV function. Patient had intermediate high-risk pulmonary embolism, and we decided to enroll this patient in the PE track trial. And for the listeners who might not be as familiar with this study, this is an NIH-sponsored clinical trial, which is specifically looking at patients with intermediate risk PE who are being randomized either to anticoagulation alone or catheter-based therapy. And this patient was randomized to catheter-based therapy.
Hold on, what options do you have for catheter-based therapies?
Yeah, it's a good question, Chris. It's basically any FDA-approved PE device at the time. So basically that allows for utilization of the Inari FlowTriever, Penumbra, lightning flash is what we've utilized in the trial, ECOS, or ultrasound-assisted catheter-directed lysis, the Bashir endovascular catheter, and then recently the AlphaVac has been approved for PE as well, although as of now, it is not approved to be utilized in the trial. That might change in the future.
Okay, gotcha.
So this is a patient that, my standard, as I mentioned earlier, when I'm treating the left pulmonary artery, we'd already done the right side thrombectomy went fine. Went to the left pulmonary artery, my standard is taking a T24 up there and then taking a T20 curved catheter, which has a better angle, which is really well situated for kind of the morphology and the shape of the left pulmonary artery. And this is one of those cases where I did multiple thrombus aspirations, and I just could not get this clot out. And it was, I found it to be extremely frustrating. So in a situation like this, what you can do is utilize these discs. This is a FlowTriever 2 disc or FT2 disc. And these have an indication for peripheral thrombectomy. And basically you advance these discs, it's almost like a stentriever in a lot of ways. You advance it into the clot, you open it up, and then you kind of, manipulate it a little bit, kind of pull it back and forth. And then after that, you go and then you do an aspiration. I did one aspiration and the entire thrombus came out. So this patient probably had, this is probably more of a subacute or even chronic thrombus in the left pulmonary artery. And without those discs, which I don't utilize very often, less than 10% of my Inari thrombectomy cases, but just is a good kind of words of wisdom for the audience. Hey, you're trying a lot of aspiration and it's not working, nothing's working. Consider those discs because it could be extremely valuable. Anyway, the patient had improved pulmonary artery pressures, had no ICU stay, was discharged 2 days later because she had to actually get the CT scan. And I saw her in follow-up recently and she has no symptoms at all. So, doing quite well. And I think I'll stop there.
Wasn't her presentation, didn't she just have 2 days of dyspnea?
Correct. Yeah, she came into a pretty severe dyspnea. When she came in, she was not looking very well. And I think she was 79 or so. She's a very very active woman. She's not one of these kind of bedbound people. She was playing tennis all the time. Doing pretty well.
So as far as using the discs, I haven't put my hands on them. Easy to use, any nuances to them, any things to be worried about, where you use them or how you use them to maybe that could put you in a spot where you're getting into trouble, or just any tips about them? Because I know when we talked about the Inari device, we've kind of gone through some best practices, but anything to shed some light on that specific tool?
Yeah, I think the main thing is just to think about it. Is if you're doing a lot of thrombectomy, utilize all your main devices and it's just not working. Just think about it. That's number one. In terms of the tips and tricks, it's relatively straightforward. You want again, all these procedures with Inari are always done over a guide wire, which I think allows for improved safety. So you're advancing this device over the guide wire into kind of where the thrombus is, and only at that point do you open up the disc, which is just a simple pin and pull. It's very easy to utilize. And then the other thing is after you utilize, you kind of do some manipulation there. You do want to do an aspiration after that. Because that by itself, just kind of pulling it into the catheter is probably not going to pull it into the catheter the same way that you might see with a stentriever for stroke. You do need to do an aspiration afterwards. So just something to keep in mind. One of my partners, actually, he did a case. This was I kind of gave it to him. He probably wasn't the happiest about it. But Andy Niekamp, who's actually now the VP of Medical Affairs at Inari. It was a Wednesday morning, and one of our vascular surgeons was doing a thrombectomy. It was a large renal cell carcinoma, and it was invading the renal vein. And during the procedure, all of a sudden, the patient became hypotensive, and he knew exactly what happened. They did an echo, and that large tumor thrombus had just embolized to the right pulmonary artery. And I had clinic that afternoon, so I called Andy. I'm like, hey, listen, can you take care of this? And so they bring this patient up. The patient's dying here. And he did multiple aspirations and got nothing out. And again, a situation like that, look, we're dealing with tumor thrombus there. Again, he utilized those discs and again got the tumor thrombus out. So again, it's just something to keep in mind when things are not really working the way they should.
That wraps things up. We'll see you next time on the BackTable podcast. Zarina, Ripal, thanks for coming on the show.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.